Hello, friends. I'll be covering a bit of series on this BTF guidelines. So this possibly can be asked as an exam for our DRNB trainees as to the guidelines in the management of severe TBI. Just an overview on the BTF guidelines. So for all the listeners, if you read the BTF guidelines, most of the guidelines they would say there is insufficient evidence to give level one or level two evidence for any of the domains. So I just want you to take you through the different dimensions that they have covered in BTF and what is it based on. So basically, I'll be looking into all the studies that they have looked into to base these guidelines. So for all the trainings, it's important that the last BTF guidelines came only in 2016. So now we are in 2024. So whatever guidelines that we would be referring to is almost close to 10 years old guidelines. So it may not be very pertinent to the current day practice in at least some of the dimensions is what would be my submission. So if you look at the BTF guidelines, so there are 18 dimensions or 18 domains. And it is divided into three parts. It's a huge document. So this is part one, where they have covered 11 dimensions. As you see, there is decompressive craniectomy, prophylactic hypothermia, hyperosmolar, CSF drainage. So I'll try to cover few of those: steroids, nutrition, prophylaxis, DVT prophylaxis, seizure prophylaxis. So, but as I said, for all of these dimensions, BTF pretty much wouldn't have level one or level two sort of an evidence substantiation, and which makes the whole guideline sort of a weaker sort of a reference to quote when in the practices that we do or incorporate or impart to this traumatic brain injury. And then you have this part two, which predominantly deals with ICP, CPP, and advanced cerebral monitoring. And then you have this part three, where they'll be talking on blood pressure, ICP threshold, CPP threshold, and cerebral monitoring threshold. So in this little overview, I'll do all these in series. So today I'll be only talking on the blood pressure targets in TBI. So I would only be talking on the BP targets in this part. Uh, so as I said, there are 18 sort of a guidelines and there are 18 domains. And blood pressure thresholds are terribly, terribly important in BTF guidelines. And why it is important? Why BP targets are important? Because in a severe traumatic brain injury, pretty much the cerebral perfusion pressure or ICP or the oxygen delivery, which we are more worried about in for the neurons in the brain, are maintained by good autoregulatory mechanisms, which I'll talk very briefly on. But when there is a severe TBI, these autoregulatory mechanisms could be lost. And these autoregulatory mechanisms are very much needed for adequate oxygen delivery to the brain cells or to the neurons. And if this autoregulatory mechanisms is impaired, that is when your blood, the whole perfusion, cerebral perfusion is very much dependent on your blood pressure. So that is where our blood pressure thresholds are important. And there are few studies done and BTF comes with the guidelines. And as I said, for all the BTF guidelines, pretty much you will see this narrative that there is insufficient evidence to give level 1 or level 2 recommendation for any of those 18 dimensions. And so is the case for this blood pressure. So we'll just try to understand why blood pressure is important and what autoregulation means. So in the brain, so just very simplistically I've shown, in the brain, you need good oxygen delivery. So, and there needs to be a good balance between the oxygen delivery and oxygen consumption. And this oxygen delivery to the brain is pretty much influenced by cerebral perfusion pressure. And what is cerebral perfusion pressure? That cerebral perfusion pressure is dependent on your blood pressure. It's mean arterial pressure minus intracranial pressure. So obviously, if your blood pressure is low, then your CPP is affected. If your ICP is high, then your CPP is affected. And when there is a normal autoregulation, when there is a normal autoregulation, what it means is there is an ongoing dynamic sort of a vasoconstriction and vasodilatation to match the balance between oxygen delivery and oxygen consumption. So there is an alternating sort of a resistance pattern in the blood vessels in the context of having normal autoregulation to match the oxygen delivery and oxygen. When this autoregulation gets impaired, that is when your blood pressure is needed to influence your cerebral perfusion pressure. So simplistically, your blood flow in the brain is directly proportional to the cerebral perfusion pressure, and it is inversely proportional to cerebral vascular resistance. So that is what we understand with what happens in autoregulation. And autoregulation, or the autoregulatory mechanism, is influenced by three dimensions. One is metabolic, myogenic, and neurogenic, and this is poorly understood. We do not understand what are all the mechanisms that are involved in the alternating resistance, vasoconstriction, vasodilatation to match oxygen delivery and consumption in the brain. There are multiple factors that influence it, maybe metabolic, myogenic, and neurogenic, and this is a very complex interplay, and it is poorly understood. And this is a beautiful graph which pretty much tells you. So there is a dilatation and constriction that automatically, there is automaticity in dilatation and constriction which will be happening in a specific blood pressure range. And if blood pressure goes to an extreme, if there is a too much of hypertension, then there is a problem with your cerebral blood flow. Or if blood pressure falls below certain critical aspect here, then there would be a compromise in your cerebral blood flow. So there is a critical sort of a range in which there is a good sort of an auto-regulation that is happening, beyond which, so at the extremes of blood pressure, either low or high, this auto-regulation is lost and there would be compromise in the blood flow. So this is what we need to understand. And auto-regulation, if it is impaired, it can cause hypoxemia and it can cause hypercapnia. So auto-regulation impairs your cerebral oxygenation, carbon dioxide, and some of the anesthetic agents also can impair. And all this will lead to cerebral ischemia. And cerebral ischemia can be precipitated or perpetuated by fall in the blood pressure. Because as you saw in the extremes of blood pressures, autoregulatory mechanisms is impaired, especially when there is severe TBI, when autoregulation is anyway impaired, your blood pressure is what influences your cerebral blood flow. And if there is reduction in mean arterial pressure, it can worsen the risk of cerebral hypoxemia. And cerebral perfusion pressure is affected by, as we know, MAP and ICP, because it is MAP minus ICP. So if there is a fall in the MAP, then your cerebral perfusion pressure can come down. Or if ICP increases, then your cerebral perfusion can come down. And it is desirable that cerebral perfusion pressure is kept more than 50 millimeter mercury, and the range is 50 to 70. Even high CPP is bad because that leads to some deleterious effects. And if there is increased ICP, there is obviously impairment of the perfusion of the brain. So let us see what happens when the CPP pressure is adequate with a fall in the ICP. So when the CPP is increased, when there is a high CPP, so obviously you would expect that the ICP is low. So that can lead to reduction of the cerebral edema. And and that can impair even your cerebral blood flow. But if CPP is more than 70, so is that good? That is also bad, because that is shown to increase your blood flow. And this increase in the cerebral blood flow can lead to worsening of the brain edema and worsening of ICP. So either way, so what this pictorially is being shown is, even if your CPP is low, so that also will reduce the cerebral blood flow. If CPP is high, it can increase the cerebral blood flow, and this increase in the cerebral blood flow can worsen the brain edema and can worsen the ICP. So both are, less CPP is bad, more CPP is bad, and we need to have a tight range. And because we are having a tight range, even the blood pressure targets also are narrow, especially where autoregulation is lost, is what we need to understand. So now coming back to what BTF suggests. So the BTF suggests that in 50 to 69 years of age, the critical threshold for systolic blood pressure is 100. It should be more than or equal to 100. Less than 100 is considered hypotensive and harmful. So this is what BTF suggests. And if it's 15 to 49 years, it should be more than or equal to 110 millimeter mercury. And if it is more than 70 years, the blood pressure target should be more than or equal to 110 ml. So it puts 110 as a range. It should not be below this, because below this is hypotension. Your CPP can be affected, and it can be affected more so when your auto-regulatory mechanisms are lost. And this is shown to, when maintaining this blood pressure and above, is shown to reduce the mortality, and may reduce mortality or may improve outcome. So now, so this is what BTF suggests. For all the trainees, the BTF suggests that you cannot allow blood pressure to be less than 110 millimeter mercury systolic for any TBI. So that is the quintessence. So where does this 110 comes from? So it is based on three important studies, and the studies are pretty old, and they're all from 2012 studies. So this was one study, redefining hypotension in traumatic brain injury. So this was published in 2012 in Injury by the US authors. So it was a retrospective cohort study. They took 15,733 patients, out of which 26.9% of these patients had GCS less than 8. And all your guidelines, the BTF guideline you see is based out of this study. So this study, they showed systolic blood pressure, if it is less than 110, so that is where it came. Your adjusted odds ratio for mortality was 1.98. It means it's significantly higher, and it attains statistical significance. And between 50 to 69, they found the critical blood pressure is 100. If it is less than that, adjusted odds ratio of mortality was 2.2. That was also statistically significant. If it was more than 70 years, critical threshold for blood pressure is 110, below which the adjusted odds of mortality was 1.2. So, based on this particular study, they have come out with 110 systolic blood pressure as a critical blood pressure, below which it should be considered hypotension. So, your BTF guidelines is based out of only this retrospective study. But there are two other adjunctive studies. So, this was another study which came in Journal of Trauma and Acute Care in 2012. Traditional systolic blood pressure targets underestimate hypotension. So this was a prospective cohort study. As you see, it was a very small study in 60 patients. So it was a very small patients, prospective cohort study in 60 patients. And here they compared systolic blood pressure of 110 versus 120. So you saw your BTF is based on the previous study, retrospective cohort of 12,000 odd patients, where they said 110 is good enough. I don't want all our trainees to remember 100 and 110, just put it as 110. But this study looked at 110 versus 120 millimeter mercury, and they looked at outcome, they looked at hospital mortality and extended Glasgow outcome score at 12 months as an outcome measure. And this study, although it's a small study, they showed 120 was superior to 110 in improving hospital mortality and in improving 12 months outcome. So you saw the retrospective first study said 110 is good enough. This particular study, which came around that time, said 120 is better than 110. So we may have to base them. That's why I said the BTF guidelines are a weak guideline, and we cannot take it as a sacrosanct. We need to look into the studies out of which it is based. And if you see the study, 120 is better. Then I'll show you the third study, which was by Butcher et al., which looked at prognostic value of admission blood pressure in traumatic. They took a large database of impact study from the UK group, and they looked at the data set to try to see the blood pressure targets. Here they looked at comparing the admission blood pressure, and they looked at Glasgow outcome score at 6 months. So they have looked at admission blood pressure and the Glasgow outcome score at 6 months, and they took a large data set. So they took 6,801 patients who had systolic blood pressure as the readings, and then they took the large data set of patients who had a map recording. So they took close to 12,000 patients, very similar to the previous study retrospective where they based on the BTF guidelines. They took this data set and interpreted how this patient perform, taking first 48 hours blood pressure and looking at the outcome. So what did they find? Best outcome in this particular study, the impact study showed if systolic blood pressure was at around 135 millimeter mercury, they had the best outcome. So we saw the BTF guidelines says 110. Then we saw a prospective cohort of 60 patients which said 120 is better. This impact study, which is also retrospective, they took the large database. They said systolic blood pressure of 135 had the best outcome, and MAP of 90 had a best outcome. And what they also found is, interestingly, what they found is if patients had a lower systolic blood pressure, then the odds of them dying was much higher, and that was statistically significant. And if systolic blood pressure was higher, then also they found that the odds ratio was 1.42, and it attained statistical significance with regards to worse outcomes. And they found lower MAP also had a worse outcome, odds ratio of 1.3, and higher MAP also had a worse outcome. So basically what they said is 135 seems to be the best fit, and higher than that or lower than whatever 110 also was poor outcome. So what we can pretty much decipher is we cannot take BTF guideline as a sacrosanct as 110, and it says it cannot give level 1 and level 2. So looking at these three studies, what possibly we should decipher is we should somewhere maintain the blood pressure between 110, because we cannot maintain at 120 all the time, we cannot maintain at 110 all the time, or we cannot maintain at 130 all the time. So possibly for all our trainees, we could, the best fit is try to maintain the blood pressure, systolic blood pressure between 110 to 135, or move more towards 120 to 135 seems to be the safe blood pressure that we should maintain in traumatic brain injury, and don't allow it to be less than at least 120. And not very high blood pressure also is found to be bad. So don't allow traumatic brain injuries to have systolic blood pressures of 180, 190, 200, so on and so forth, because this particular impact sort of a data shows it leads to bad outcomes. So for the take home message is try to maintain normotension. That's why we maintain 7 normos. So maintain between 120 to 135 systolic, or at least look in ICU, we look at the map, maintain 90, but don't maintain map of 100, 120. So that's the message from the BTF guidelines, and more, not from BTF, more so looking into the studies that have looked into the blood pressure targets in traumatic brain injury. So I request all our esteemed listeners to attend to our signature conference JIX that's happening from 18 to 20th October, and request all of you to submit valuable work to Journal of Acute Care, which comes out every 3 months. And visit my website www.drpadeep.com to read this. Thank you. Thank you, Vandal.